So when you think of modern medicine, you probably picture this perfectly mapped out, highly regulated highway.
Right, yeah, like with incredibly clear signs and established speed limits.
Exactly. And like thick, heavy rule books dictating every single turn a doctor might take.
Standardized guidelines are, they're the bedrock of that entire system. The whole infrastructure is basically designed to be predictable and measurable across the board.
But if you take a detour into certain areas of intimate healthcare, suddenly the pavement just ends, like you are completely off-roading.
Oh, absolutely.
We're entering what you could really call the medical frontier. These rapidly evolving areas of healthcare where clinical practice is just moving at lightning speed.
And leaving those official rule books completely in the dust.
Yeah, exactly. So today's deep dive is exploring exactly what happens when patients seek out this deeply personal care that the medical establishment, well, they simply haven't fully figured out yet.
It's a really fascinating space to look into.
It is. And we have a really great stack of sources to guide us through this frontier today. We are looking at clinical scoping reviews on platelet-rich plasma, or PRP, in gynecology.
Right, alongside the actual promotional materials from clinics,
Yeah.
offering what they call the O-shot.
Right. But to balance out that clinic hype, we're also bringing in a strict medical clinical policy bulletin from Aetna Insurance.
Always good to get the insurance perspective, yeah.
Yeah, definitely. And finally, a brand new, honestly eye-opening national survey on breast cancer screening for transgender patients.
So the mission tying all these diverse documents together is really this need to separate medical hype from physiological reality.
Right.
We're trying to examine the immense friction between what patients desperately need for their quality of life, what these specialized clinics are boldly offering them, and what the strict evidence-based insurance guidelines are actually willing to endorse and pay for.
Which is a huge gap. And I feel like the best place to start unpackaging that friction is with the vampire facial that went south. And by south, I mean all the way down to the pelvic floor. We have to talk about the underlying science of the O-shot.
Also known as the V-shot in some of the promotional materials, or just vaginal PRP therapy.
Right. And these clinics, they're promising the moon. They're advertising everything from enhanced intimacy to curing chronic pain. But before we even touch those claims, let's demystify the actual mechanics of platelet-rich plasma. Like, how is this actually functioning on a biological level?
Well, the process starts in a very straightforward, almost mundane way, really. A clinician just does a simple blood draw from the patient's arm.
Just like a normal physical.
Exactly, yeah. They take about 15 milliliters of blood, and then that vial is placed into a centrifuge, which is a machine that spins the sample at incredibly high speeds.
Like a high-tech salad spinner.
Basically, yeah. It spins it to stratify the blood based on density. So the heavy red blood cells, they sink to the absolute bottom of the tube.
Okay, making sense so far.
And what you're left with, suspended at the top, is the plasma. It's been stripped of the red blood cells, but it retains this massive, hyperdense concentration of platelets.
Which, most people hear platelets and immediately think of scabs, right?
Right, yeah.
They're the little biological corks that make your blood clot when you get a paper cut so you just don't bleed out.
They absolutely do that, but, clotting is really only phase one of their job.
Oh, really?
Yeah, beyond forming a plug, platelets are essentially these tiny specialized reservoirs packed with growth factors. Once they actually arrive at the site of an injury, they release bioactive molecules.
Okay, bioactive molecules.
Yeah, they have these alphabet soup names like PDGF, VEGF, and PGF-beta. But basically, these molecules are the body's primary chemical messengers for tissue repair.
Okay, let's isolate VEGF for a second. That's vascular endothelial growth factor.
That's the one.
So vascular refers to veins and blood. So this is a molecule that literally commands the body to build brand new blood vessels from scratch.
Exactly. It stimulates a process called neovascularization. So when VEGF is released into a localized area of tissue, it basically signals the existing blood vessels to sprout new capillaries.
Wow.
Yeah. It floods the area with increased blood flow and oxygen.
Mm-hmm.
And then other growth factors in that plasma, they stimulate fibroblasts to ramp up collagen and elastin production.
So it's driving overall structural tissue regeneration.
Precisely. But to actually harness this in a clinical setting, you take this super concentrated plasma and you have to prepare it for delivery. So often, a chemical catalyst like calcium chloride is added to the serum.
Okay, why calcium chloride?
Well, it activates what is known as the thrombin cascade.
So the calcium chloride basically acts as an alarm clock then. Like, it tricks the platelets into thinking a massive injury has just occurred, waking them up and forcing them to start dumping those growth factors into the serum before it even enters the body.
That is exactly the goal of chemical activation, yes. But some of our sources highlighted even more advanced technologies for this, specifically something called the Arthrex ACP system.
Okay, how is that different?
Well, instead of relying on harsh chemical activators to force that rapid dump of growth factors, the Arthrex system centrifuges the blood in a way that creates a platelet-rich fibrin matrix, or PRFM.
A fibrin matrix? That sounds like a biological net.
That is a perfect way to visualize it, honestly. It acts as this microscopic scaffolding. So when it's injected, this matrix physically holds the platelets and growth factors in place within the tissue.
So they don't just wash away in the bloodstream right away.
Exactly. It prevents that.
Yeah.
Which allows for a much slower, sustained, and controlled release of regenerative factors over several days or even weeks. And it actually accomplishes this without needing any artificial anticoagulants mixed in.
Which brings us to the delivery mechanism, which is, a part of the procedure that might make some listeners wince a little bit.
It's an intense procedure.
Right. So after applying a heavy topical numbing cream, this highly active serum is injected directly into the anterior vaginal wall, the clitoris, and the periurethral area.
Sensitive tissue directly surrounding the urethra, yeah.
Yeah. I'm just trying to visualize the biological intent here. It sounds like a garden where the soil has become completely depleted and the roots are dying.
Okay, I like this analogy.
Right. So instead of just pouring water on it, you are extracting the absolute most potent customized fertilizer directly from the plant itself, hyper-concentrating it in a lab, and then injecting it directly back into the failing root system to force this massive, unnatural spring bloom.
I mean, the fertilizer analogy captures the optimistic intent of the therapy perfectly. Like, clinics love to market this as a gentle, elegant, perfectly choreographed spring bloom.
But is it?
If you look at the cellular reality, injecting a massive, highly concentrated dose of activated growth factors into delicate tissue, it's a lot more like opening a chaotic biological construction site.
Construction site?
Yeah, you are intentionally triggering a localized inflammatory response. You're causing microtrauma with the needle itself and then flooding the area with signals that force the existing tissue to rapidly break down and remodel itself.
So it's a highly aggressive biological intervention, not some soothing balm.
Exactly.
Well, let's look at what that biological construction site is supposedly building, because the spectrum of conditions the OSHOT claims to treat is just staggering.
It really is.
It spans the entire gap between a weekend cosmetic enhancement and a serious, life-altering medical intervention. Like, the lifestyle claims are definitely the loudest in the promotional materials.
Oh, for sure. Increased libido, stronger orgasms.
Right. Clinics are advertising that this localized inflammation and remodeling will dramatically increase libido, create much more frequent orgasms, enhance natural vaginal lubrication, and even tighten the vaginal canal.
And those are the claims really driving the commercial popularity of the OSHOT. However, the clinical scoping reviews from the peer-reviewed literature, they paint a very different picture.
Because they focus on the heavy-hitting pathological medical applications.
Right. The reviewers examined PRP as a primary treatment for vulvar lichen sclerosis, or VLS.
Which is a severe chronic autoimmune condition, right?
It is. It causes the skin of the vulva to thin out, tear, and scar. It leads to just excruciating pain during intimacy or, honestly, even just basic daily movement.
And one of the studies in the scoping review tracked patients with VLS who underwent PRP therapy, and the statistics are almost unbelievable to me.
The results were dramatic.
Over 80% of the patients with this chronic, incredibly stubborn condition were able to completely discontinue their use of high-potency steroid creams after their PRP treatments.
Achieving an 80% discontinuation rate for topical steroids in a VLS population is a monumental clinical outcome. I mean, steroids merely manage the inflammation, and they often cause further skin thinning over time.
Right, making it worse in the long run.
Yeah, so the literature suggests PRP is actively repairing the architectural integrity of the damaged skin.
Wow.
And the scoping review also detailed PRP's effectiveness for stress urinary incontinence, or SUI.
Which is that incredibly common, really frustrating condition where a weakened pelvic floor allows urine to leak when a patient coughs, sneezes, or laughs.
Exactly. And most profoundly, The medical literature contains reports of PRP being utilized for survivors of female genital mutilation.
Yeah, the sources documented cases where FGM survivors underwent surgical reconstruction of their anatomy, followed by targeted PRP injections. And the reports noted not just complete pain relief, but significant sensory nerve regeneration.
They were literally regrowing severed nerve pathways.
Right, which actually makes me wonder about other reconstructive surgeries. Like, a big question in this space is, can an O-shot be administered to transgender women following a penoscrotal inversion vaginoplasty? Specifically to support neovaginal sensation.
That is exactly the kind of question where the biological logic points next. Yeah, the idea is that if you're dealing with surgically reconstructed tissue, like a neovagina, injecting PRP could theoretically stimulate that exact same nerve regeneration and tissue health we see in the FGM reconstruction cases.
Because it's relying on that same foundational mechanism.
Exactly. You're trying to promote neovascularization and nerve growth in newly constructed tissue. Now, the clinical evidence there is even further out on the frontier, but biologically, the rationale completely tracks with what we're seeing.
Okay, but I have to push back hard here for a second because from a listener's perspective, this sounds suspiciously like 19th century snake oil.
I know, it really does.
Like, how can one single injection of spun blood be a magic bullet for low libido, urinary incontinence, and autoimmune skin disease, and regrowing severed nerves and reconstructive surgeries? I mean, it defies common sense that one treatment does all of that.
It sounds completely paradoxical until you strip away the disease names and look exclusively at the underlying mechanics of the pelvic floor.
Okay, explain that.
Well, the pelvic region is this dense, interdependent web of sensory nerves, blood vessels, and supportive structural connective tissue. When you inject PRP into this space, you are essentially pulling a single biological lever.
What?
You are triggering neovascularization and collagen synthesis. You are telling the body to build more blood supply and more structural scaffolding.
So the biological tool never changes, but the location dictates the cure.
Exactly that. If a patient has sexual dysfunction or nerve damage from FGM or vaginoplasty, injecting PRP near the clitoris and anterior vaginal wall uses that new blood flow and collagen to repair degraded sensory pathways, which directly impacts arousal and pain relief.
Right.
But if you take that exact same syringe and inject it into the periurethral area for a patient with incontinence, you aren't trying to bend nerves.
Right, you're trying to stop leaks.
Yeah, you are using that new collagen to physically bulk up and strengthen the weakened structural walls surrounding the urethral sphincter, restoring its mechanical ability to hold back urine.
So it isn't a magic bullet curing 10 different diseases. It is one biological mechanism, aggressive tissue remodeling, solving two vastly different mechanical failures in the same neighborhood.
Right. The science possesses immense biological plausibility. The mechanism just makes complete sense on a cellular level.
But the insurance companies are completely ignoring that biological plausibility. And this is where the medical frontier gets incredibly messy.
Oh, very messy.
Because we have glowing clinical outcomes colliding violently with the rigid skepticism of standardized medicine. We reviewed a medical clinical policy bulletin directly from Aetna regarding female sexual dysfunction and incontinence treatments.
And they do not hold back.
No, they don't. The bulletin flatly states there is no clear evidence that PRP improves either condition. Aetna points to a severe risk of bias in the current studies.
Right.
And they specifically cite a randomized controlled trial demonstrating that traditional surgical mid-urethral slings worked significantly better for curing incontinence than PRP injections ever did.
And I mean, Aetna's skepticism is entirely justified by the rules of evidence-based medicine. If you comb through the fine print of that clinical scoping review, the researchers themselves highlight massive glaring reporting gaps across the entire PRP literature.
Like what?
Well, the clinics and researchers championing this therapy are completely failing to standardize the most basic elements of the treatment.
Right, like they aren't standardizing the platelet concentration from one study to the next.
Oh, no.
They aren't standardizing the activation strategies, like some use calcium chloride, some use the Arthrex fibrin matrix we talked about, some use nothing at all.
And they also failed to standardize the leukocyte content, which is a critical variable.
Leukocytes are white blood cells, right?
Yeah, white blood cells. Some centrifuge systems leave high concentrations of white blood cells in the plasma, which creates leukocyte-rich PRP. And white blood cells actively drive inflammation.
Okay.
But other clinics deliberately spin them out to create leukocyte-poor PRP to minimize inflammation.
Wait, so a patient getting an O shot at a clinic in New York might be receiving a biologically aggressive, highly inflammatory serum, while a patient getting the exact same medically branded O shot in California is receiving a completely different slow-release matrix.
Exactly. The product shares the same name, but biologically, they are entirely different therapies. And this exposes the fundamental structural flaw in studying PRP. It is an autologous therapy.
Meaning the medicine is harvested directly from the patient's own body.
Yes, because the raw material comes from you, every single dose ever administered in the history of the therapy is biologically unique.
Wow, yeah, I guess so.
Your blood plasma has a different baseline platelet count than my plasma. And furthermore, your plasma today is radically different from your plasma next week. It fluctuates based on your hydration levels, your recent diet, your systemic stress, and even your sleep quality.
So you just cannot standardize it the way you standardize a traditional pharmaceutical.
You can.
Like if I take an over-the-counter aspirin, I know that every single pill in the bottle contains precisely 325 milligrams of the active ingredient, no matter who manufactures it.
And that standardization is the absolute prerequisite for a double-blind, randomized controlled trial. How do you definitively prove the clinical efficacy of a drug across a population of 10,000 people when the active ingredient chemically morphs and changes with every single patient who receives it?
You can't. It is a statistical nightmare for guideline writers.
It's a double nightmare, yeah.
Which really leaves the patient stranded.
Yeah.
I mean, you have a therapy with highly logical biological mechanics, virtually zero risk of rejection because it's your own tissue, and thousands of passionate patient testimonials.
Right.
Yet the gatekeepers of modern medicine, the insurance actuaries, look at the data and say insufficient evidence, request denied.
Yep.
So patients are forced to navigate this frontier entirely out of pocket, relying on slick clinic marketing rather than a unified medical consensus.
And this exact friction, where complex biological reality outpaces the official rulebook, it doesn't just stop at experimental, out-of-pocket treatments. It bleeds right into standard life-or-death preventative care, too.
Which brings us to a massive gap in intimate health guidelines found in our sources. The total lack of consensus around breast cancer screening following gender-affirming mastectomy, or GAM, for transgender patients.
This is such a critical issue.
It really is. To lay the groundwork here, when a transgender man or non-binary patient undergoes a gender-affirming mastectomy, the surgical goal isn't always the total eradication of every single breast cell. Like it might be in an oncological mastectomy, right?
Right, exactly. The surgeon often intentionally preserves small amounts of residual breast tissue. This might be to ensure a healthy blood supply to a nipple graft, or just to achieve a specific natural-looking masculine contour on the chest wall.
But because that residual glandular tissue remains in the body, it leaves a very real, non-zero risk of breast cancer developing in that exact tissue decades later.
Yes, and the clinical dilemma is not whether the risk exists. The dilemma is how doctors are supposed to screen for it. A brand new national survey investigated this exact blind spot.
And they gathered incredibly detailed data from 586 plastic surgeons and 101 breast surgeons across the country.
Yeah, and the findings reveal a medical system that is just fundamentally fractured. I mean, across all these highly trained specialists, roughly a third of the doctors surveyed were completely unaware that any screening recommendations for transgender patients even existed.
A third?
Yeah. Furthermore, 4 in 10 providers explicitly reported that they do not adhere to any specific screening guidelines for this population.
That's wild. And the survey designers presented all of these surgeons with a single theoretical average risk patient profile, right? Just to see how they would handle the exact same scenario.
Right. And the lack of clinical consensus was staggering. For one identical patient, the plastic surgeons provided 25 distinct screening recommendations.
25.
And the breast surgeons looking at that same patient profile provided 16 distinct recommendations.
Just imagine being a patient navigating that system. You could walk into 40 different specialty clinics in the same city, present the exact same medical history and the exact same chest, and receive 40 completely different answers on how to ensure you don't die of cancer.
It's terrifying.
Some might recommend an annual MRI, some an ultrasound, some a physical exam, and some might say you need nothing at all. As a result of this chaos, barely a quarter of the providers surveyed actually felt confident in the medical recommendations they were giving their patients.
The survey data exposes a deep-seated medical tribalism at play here.
How so?
Well, the plastic surgeons lean heavily toward the guidelines published by WPATH. That's the World Professional Association for Transgender Health. But in stark contrast, the oncological breast surgeons almost universally favor the criteria published by the ACR, the American College of Radiology.
Why are these two highly respected medical specialties reading from completely different maps for the exact same patient?
It really comes down to the underlying philosophy of their specific medical disciplines. WPATH views the patient holistically, right? Their guidelines prioritize the success of the gender transition, minimizing gender dysphoria, and integrating mental health with physical outcomes.
Right, so a plastic surgeon operating under WPPath is evaluating that residual tissue through the lens of an affirmed masculine chest.
Exactly. But the ACR, however, views the patient purely through the lens of radiological cancer risk.
They're just looking for cancer.
Right. A breast surgeon operating under ACR guidelines is trained to hunt for tumors. They view any residual glandular tissue strictly as a potential malignancy zone, regardless of the patient's affirmed gender identity. They're literally speaking two entirely different medical languages about the exact same tissue.
If I am a patient caught in the middle of this tribalism, how am I supposed to advocate for my own health when the leading experts cannot even agree on the basic foundational rules of my anatomy?
It places an incredibly unfair burden of self-education on the patient. You cannot assume your doctor has a definitive playbook anymore. You have to proactively ask your provider which specific guidelines they are following, why they chose those guidelines over others, and what the blind spots those guidelines might actually be. This survey perfectly encapsulates the overarching reality of the medical frontier.
Yeah, it does. Whether it is a cisgender woman seeking out an autologous blood serum to cure severe vulvar pain, or a transgender man simply trying to get a routine, safe cancer screening after a transition-related surgery, patients navigating these deeply intimate spheres of healthcare are often forced to be their own medical pioneers.
They're forced into that role because the universally accepted evidence-based guidelines just haven't caught up to the complex reality of the care being provided today.
Yeah.
The biological science and the surgical realities are moving far faster than the insurance bureaucracies and the institutional consensus. And the doctors feel this friction too. Over 93% of both the plastic and breast surgeons surveyed agreed that the medical community desperately needs unified, evidence-based, transgender-specific screening guidelines.
Because until those thick, heavy rulebooks are actually written and agreed upon by everyone, the heavy burden of proof and, the terrifying burden of risk falls squarely onto the shoulders of the patient.
It does.
The medical frontier is undeniably fascinating, but it is deeply messy and largely unregulated. We have seen today that innovations like PRP offer immense, life-altering hope.
They do.
They literally leverage the chemical messengers inside our own blood to regenerate failing tissue, offering highly plausible solutions for debilitating conditions that traditional medicine often ignores.
But, the unique, ever-changing nature of our own biology means these autologous therapies inherently lack the standardized, reproducible proof that modern medical infrastructure demands. Meanwhile, essential, life-saving preventative care is trapped in a chaotic web of conflicting specialist opinions.
So being well-informed in this landscape means fundamentally understanding the difference between a biologically promising therapy and an institutionally proven one. It means realizing that when you step off the perfectly paved highway and into these intimate spheres of healthcare, your doctor isn't always holding a map. Often, they're navigating the gray areas right alongside you.
It demands a major shift in how we approach our own health. We can no longer afford to be like passive recipients of care. We have to actively help our providers chart the course.
Absolutely. And we want to leave you with a final thought to mull over as you navigate your own care. We have spent this deep dive exploring how injecting a vial of our own spun blood can potentially command the body to build new blood vessels and regenerate severed nerve tissue.
Right.
We've explored how our physical anatomy can be surgically altered and affirmed to match our true identities. So, if our flesh and our nerves are truly this malleable, how much of what we consider to be permanent, fixed, or irreversible about our own biology is actually just waiting for the right medical catalyst?